Hello people, this is Dr Muskaan this side, and today I am going to discuss one very beautiful case which I have studied in ICU that was all about community acquired pneumonia. And this time I am going to discuss case with very basic steps. For example, if the chief complaint has came of shortness of breath, I am going to tell you here what are the differentials you have to think in your mind. If there is tachypnea in the patient, I am going to tell you what are the differentials you have to think in your mind. It might seem boring for those who are listening just to gather some information which is at the superficial level, and it is going to be very interesting video for those who are going to listen this video to go in the depth of the case. Okay, so I really enjoyed working on this case and I would like to share this case with you. Let's dive into the story of this patient. So yes, here is 50-year-old male who has came to ER with chief complaint of shortness of breath since 10 days. Thinking shortness of breath in my mind, I came with differentials according to hypoxemic criteria, hypercapnia, acidemia, poor oxygen delivery and miscellaneous. So if I am thinking about, okay, this patient is feeling shortness of breath because of hypoxemia, so the differentials which will come in my mind will be pulmonary edema, pneumonia, pulmonary embolism, pleural effusion, COPD, pneumothorax, atelectasis, or any mucus plaque. If I am thinking on the line of hypercapnia, that means high carbon dioxide in this patient, so it can be COPD exacerbation, asthma exacerbation, or it can be any neurovascular disease such as myasthenia gravis, transverse myelitis, or Guillain-Barré syndrome. If I am thinking on the line of acidemia, that this patient is feeling shortness of breath because of acidemia, so I will think on the line of ketoacidosis or lactic acidosis, which may be raised in this patient. If the reason is poor oxygen delivery without hypoxemia, the reason can be obstructive shock. It can be massive pleural effusion, it can be tamponade, it can be tension pneumothorax. And miscellaneous are upper airway obstruction, in which there will be coming anaphylaxis, angioedema, infection, anxiety and pain. Now what I want to ask you, just ask this question from yourself. What is difference between upper airway and lower airway? Going into very basics, because I told you miscellaneous may there is upper airway obstruction. So my dear friends, upper airway comes like external nose, then nasal cavity, then pharynx, and your lower airway comprises of larynx, trachea, bronchi and then lungs. Okay, so I told you differentials of shortness of breath in detail, and if you want to learn the differentials of shortness of breath in at level that you remember those, I made one mnemonic that if it is including heart, the mnemonic is FMT, that is F stands for failure, that means heart failure, M stands for MI, and T stands for tamponade, that is cardiac tamponade. And if the differentials is at the level of lungs, so I have to think of 3 P's and 3 A. 3 P stands for pleural effusion, pneumothorax, pneumonia. Okay, pneumothorax is tension pneumothorax. Okay, and A stands for anaphylaxis, asthma and your angioedema. Okay, aspiration also it can be, and COPD is one of the differential which will be included in the criteria of lung for shortness of breath. So I talked about differentials of shortness of breath in great detail with you. Now I am going to tell you, after thinking this, what we have to do. If patient comes with complaint of shortness of breath, what ER people are going to do? They are going to do primary survey, of course. They will do A, B, C, S. A stands for airway, B stands for breathing, C stands for circulation, and S stands for sensorium. So in airway, what we check? We check it is patent or not. So in my case, airway is patent. There were no signs of airway obstruction. Okay, I am telling you that airway was patent because there were no signs of airway obstruction. So what are signs of airway obstruction? And if signs of airway obstruction are present, what people of ER are going to do? They are going to intubate the patient. Okay, and signs of airway obstruction are dyspnea, dysphonia, dysphagia, stridor, choking. Patient is holding his neck and saying, I'm not feeling like breathing. Hoarseness of voice. It can be drooling. Drooling means saliva. He's not able to engulf his saliva also. Okay, he's lying down or sitting position, he's not able to breathe properly. That means airway is not patent. Okay, these are the signs of airway obstruction. So if they are present, we have to intubate the patient. If they are not present, we have to not intubate the patient. So this is all about airway assessment. Now I am going to B, that is breathing assessment. In breathing assessment, we check 2 points. One is your respiratory rate, another is your SpO2. Respiratory rate can be more or less. If it is more, it is tachypnea. If it is less, it is bradypnea. In SpO2, we check desaturation. Okay, so in my case, respiratory rate was 30 per minute, that means tachypnea. Normal respiratory rate is 12 to 18 per minute. So there was labored breathing. SpO2 was 97% on oxygen. On how much oxygen he was? 10 liter oxygen. So when breathing is compromised, we think about lung parenchymal part. We think to intubate or either give oxygen support through nasal prongs or NIV or FHNC according to the need of the patient. Now, what are the differentials of tachypnea? Because my patient is in tachypnea and it is most important to think differentials here. That is how we will lead to diagnosis of our case, है ना? So there are various criteria, various categories in differentials of tachypnea. One is pulmonary, other is cardiac, third is hematologic, fourth is your metabolic, fifth is your nervous system, sixth is your endocrine, and seventh is your other causes. I will discuss with you at a very fast speed. It is all things which you have to remember, or I can say you to mug it up. So pulmonary differentials are for tachypnea is asthma, COPD, pneumonia, congestive heart failure, pneumothorax, upper airway obstruction, and PVMF, that is paradoxical vocal fluid motion. Cardiac differentials for tachypnea are pulmonary embolism, cardiac ischemia, pericardial effusion, and tamponade. Hematological differentials are anemia. Metabolic differentials are metabolic. See, it is easy to remember metabolic differentials. How I have remembered poisoning and acidosis. In acidosis, we have to remember metabolic acidosis, diabetic ketoacidosis, your lactic acidosis, and ketoacidosis, 4 acidosis. And in poisoning, you have to remember salicylate poisoning, carbon monoxide poisoning, and other metabolic differentials are patient is feeling dehydrated, he's on alcohol, he's starving, or there can be severe kidney dysfunction. Nervous system dysfunction are post-ictal or grand mal seizures, brainstem pathology. Okay, central neurogenic hyperventilation. Endocrine differentials are hypothyroidism, pseudocytochroma, and other causes can be fever, it can be sepsis, it can be psychiatric cause, that is pain, anxiety, or fright, or it can be physiological response also. After exercise we feel tachypnic. So these are all differentials of tachypnea. On circulation assessment, pulse rate was 116 per minute and BP was 140/70. That shows the patient was tachycardic and hypertensive. Sensorium was alert, GCS was E4, V5, M6. So GCS was 15/15. Means he was opening eyes spontaneously. Verbal response was oriented, and motor responses he was obeying command. HOPI patient was apparently asymptomatic 10 days back when he developed shortness of breath associated with cough with expectoration. Since 10 days, it is increased on seasonal variations, that is more in winters from past 10 years. There is negative history of loss of appetite, loss of weight, dust allergy, hemoptysis, MDI or DPI use. MDI means metered dose inhaler and DPI is dry powder inhaler. Past history, he took antitubercular therapy for 6 months. 8 years back, there was history of hyperthyroidism, which is recently diagnosed, and he's on regular medications for that. There is history of type 2 diabetes mellitus. HbA1c level was 7.4%. There is no history of hypertension. Personal history, he's ex-smoker since 30 years. He left smoking 5 years back. He's ex-alcoholic. He left alcohol 3 months back. He's tobacco chewer from last 30 years. Investigations, CBC picture shows anemia and leukocytosis. KFT picture shows hypokalemia, hypochloremia, and increase in urea. LFT picture shows serum transaminitis, decreased total protein, hypoalbuminemia, and increased alkaline phosphatase level. ABG picture shows metabolic alkalosis. Anion gap shows NAGMA, that is normal anion gap metabolic acidosis. Okay, what is your causes for NAGMA? there is one mnemonic called as USED part, USEDPART. U stands for urinary diversion, S stands for small bowel fistula, E stands for extrachloride, D stands for diarrhea, P stands for pancreatic fistula, A stands for Edison, R stands for road traffic accident, and T stands for tenoffer. ECG shows there was no axis deviation. Thyroid profile shows hypothyroidism. In blood culture there was no growth. NT-proBNP level was 4041.36 picogram per ml. What is NT-proBNP, my dear friends? NT-proBNP is N-terminal prohormone of brain natriuretic peptide. Okay, N-terminal pro-brain natriuretic peptide. So if its level is more than 125 picogram per ml, it indicates acute heart failure. So it is one of the protein which is found in heart. And what happens basically, this protein was first found in brain tissue, that's why brain comes in its name. And basically left ventricle is the main part of the heart which pumps blood to the whole body, है So because when stress is there in left ventricle because of more blood, it causes injury and it increases the level of NT-proBNP. So when levels of NT-proBNP are increased, they tell to kidney promptly to relieve salt in water. That's why in their name comes natri for sodium and diuretic for water. Okay. So whenever you will come to know about NT-proBNP reports, what you have to think about: acute heart failure. It is indicating towards that. But NT-proBNP is not the perfect marker to say it is acute heart failure. For that we see the reports of troponin I. If its level is more than 0.04, that means there is 100% sure chances of acute heart failure. But if it's only NT-proBNP positive and troponin I negative, that means it is suggesting us that it can be heart failure, but it is not that. Okay. Next, prothrombin time. Prothrombin time was increased in my patient. What is prothrombin time? Prothrombin time measures clotting time of plasma. Raised prothrombin time has clinical significance. It tells about DIC, liver disease, vitamin K deficiency, oral anticoagulant therapy, factor 5, 8, 10 deficiency, and when there is massive transfusion for blood. INR was normal in my patient. D-dimer was also increased. What is D-dimer? Report tells D-dimer is a protein fragment which is produced when blood clot breaks down in our body. So what are the causes of D-dimer? If there is high D-dimer, so there is significant blood clotting. Okay, it can lead to DVT, it can lead to pulmonary embolism, it can lead to DIC, stroke, or COVID infection. If it is false positive, D-dimer positive, so the reason can be advanced age, smoking, obesity, pregnancy, surgery, trauma, infection, heart disease, rheumatoid arthritis. AFB stain sputum of the patient shows no acid-fast bacilli. Peripheral smear shows normocytic, normochromic to microcytic hypochromic anemia. Gene expert of the sputum says that there is no Mycobacterium tuberculosis detected. HbA1c level was 7.4%. And what is HbA1c? Hemoglobin A1c. This is a blood test basically, which shows the average blood glucose or the sugar level from past 2 to 3 months. If it is more than 6.6%, that means patient is diabetic. Troponin I in my patient was 0.02 nanogram per ml. I told you about NT-proBNP and troponin I relation. Okay, so it was kind of normal. It is not more than 0.04. So what is troponin I? Basically, these proteins are released when heart muscles get damaged, such as it occurs in heart attack. Okay, so sputum culture and sensitivity shows Pseudomonas aeruginosa. Pus culture and sensitivity shows Staphylococcus aureus, which was methicillin resistance and E. coli. Ultrasound whole abdomen shows bilateral renal calculi. HBsAg, HCV, HIV 1 and 2 was non-reactive. And sepsis protocol was seen in this patient. SIRS, that is systemic inflammatory response syndrome. Heart rate was increased and respiratory rate was increased. So with 2 SIRs there was infection also. TLC count was 12K, that means sepsis is also there. In severe sepsis, we have to see three things, that is end organ damage, lactate level should be increased above 4, and sepsis should be present. So all three criteria were not met because lactic acid level was not more than 4, it was just 2.8. So our sepsis protocol was ended at the level of sepsis only. Because how we check sepsis protocol? SIRs, then sepsis, then severe sepsis, then septic shock. How we check it? In SIRs we see four things, that is your respiratory rate, fever, heart rate, and your blood pressure. Sometimes we see ABG also. Okay, this is SIR, so 2 SIR should be positive to go to the next step. In sepsis, we say that 2 SIR positive plus infection. In infection, we can check if there is any growth in blood culture or urine culture, or we can see the TLC level if it is increased. In severe sepsis, we see three things. One is your sepsis, means it should come, all those criteria of sepsis should met, and then we see the lactic acid level, it should be more than 4, and there should be some end organ damage should be present. End organ damage means AKI, LFT picture should be deranged, or it can be your cardiovascular problem, है ना, कोई भी एक organ में body में there should be some problem. In septic shock, we say that it is persistent, all these factors, so then we say septic shock. Okay, next is your curve 65 criteria for pneumonia. What is curve 65? C stands for your confusion, U stands for urea, which is more than 7, R stands for respiratory rate, which is more than 30, B stands for systolic blood pressure or diastolic blood pressure. Systolic blood pressure less than 90 or diastolic blood pressure less than 60. 65 stands for age should be more than 65. So these are 5 points: confusion, urea more than 7, respiratory more than 30, the blood pressure should be in hypertension, and 65 means age more than 65. If curve 65 criteria, it lies in 0 to 1 point, it is first risk group and we can do home management. If it is in if the total is 2 points, the risk group is 2, then we can do OPD manage. If the total points come out to be 3 to 5, it is third risk group and we need ICU management. Okay. For this patient. So as we have seen in culture growth, there was pseudomonas positive. So what all differentials should come in mind? Differentials will be pneumonia, septicemia, meningitis, endocarditis, endophthalmitis, and malignant external otitis. Okay, so what is the management we have given to this patient? I will tell you the antibiotics. First is tablet carbimazole, which was given for hyperthyroidism. Injection Pantop was given for GRD. Repsule Intergermina was given to treat diarrhea, because we have seen that in blood culture reports E. coli was positive. Injection Lasix is given, which is diuretic, which is given to increase urine production. Injection Velimixin is given to treat bacterial infection. Injection Metronidazole is given to treat GID infections. Nebulization with Dulene was done to treat reversible bronchospasm. Dulene is combination of ipratropium and levosalbutamol. Nebulization with Budecort was done to prevent the symptoms of asthma, that is wheezing and shortness of breath. Nebulization with Mucomix was done to clear mucous secretions. Injection Hydrocort was done given to treat swelling, redness, itching, and allergic reactions. Injection Flucan was given to treat fungal infection. Injection Mucomyst was given to clear airway secretions. Injection NORAD was given to treat hypotension, and when diastolic blood pressure does not increases, we give injection vasopressin with it to treat hypotension. Injection fentanyl was given to treat sedation and to induce sedation, and injection phosphorus was given to treat hypokalemia. So the last diagnosis of this patient was community acquired pneumonia with sepsis, with type 2 diabetes mellitus, with hyperthyroidism. So I really enjoyed working on this case. Why? Because I learned the differentials of shortness of breath, I learned the differentials of tachypnea, I learned the causes of NAGMA. These all are important for lifetime, my dear friends. Okay, I learned the reason why prothrombin time are increased and what is its clinical significance, what are the differentials of false positive and true positive D dimer test. I learned about curb 65 criteria for pneumonia. Actually, I learned that before also, but I generally forget one or two point of that, but I just revise it again while studying this case. I learned the differentials of pseudomonas in culture while studying this case. So I really love medicine from my heart because it is like a fun game for me. So I hope you have also enjoyed listening to this case, and hopefully you are benefited by listening the history of this patient. That's all. Dr. Muskaan Bansal is signing off now.